Well, you are most welcome to today's talk. It is Wednesday, the 4th of March 2020. And this is a day I have been anticipating and dreading for quite some time. I anticipated it back in January when I first realised the transmission characteristics of this virus, COVID-19 virus. And it's happened today. The first 2 cases have been reported in my city. I live in a small city in the north of England called Carlisle, and today we have 2 reported cases. So not unanticipated, but certainly not welcome. So let's look at where we're at in the more global scale of things. It's Wednesday, the 4th of March, right? 84 countries now reporting 1 or more cases of the virus. 94,250 global confirmed cases according to the Johns Hopkins website. I stress these are confirmed cases. This is the tip of the iceberg. We know that. There's many, many more cases than that. Sadly, I must report 3,215 deaths to date. But it's also good to report that 51,026 cases are reported to have been cured or now fully recovered. So that's good. Now, I wanted to say something about testing today. Now, we have mentioned this in the past because the current state of testing is unsatisfactory for a couple of reasons. Now, I have watched people being tested on videos from around the world, and sometimes they take nose swabs and sometimes they take mouth swabs, which is fine. But this infection is actually primarily down in the lungs. So sputum that you cough up from down in your lungs is actually better and is going to contain more viruses. So sputum is best for PCR, this test. We have polymerized chain reaction tests. And this is a test for the antigen. It's a test for the COVID-19 virus. It's not a test for the antibody. We don't have an antibody test yet. Now, the Chinese and the scientists in Singapore have claimed some success with antibody tests, but they're not yet available. I just want to briefly say what we mean by that. The virus is an antigen. We have done this before, but the virus is an antigen. An antigen being something that your immune system recognises as being foreign. And the antigen stimulates your immune system to produce an antibody. And an antibody is an immunoglobulin, an immune protein. And it's the antibody or the immunoglobulin that then will attack and kill the antigen. So the antigen, the virus, causes the disease. That's what causes the disease. The body responds by producing this wonderful complex immune protein. It takes it a couple of weeks to get a good number of these immune proteins, these antibodies or immunoglobulins, that will then destroy the antigen, destroy the virus. Now, that means when you have the infection, the antigen will be present. That's what this is testing for. The PCR test is testing for the presence of the antigen. But then the immunoglobulin, the antibody, should get rid of the antigen. So afterwards, we don't know quite how long afterwards, a week or 2 after you have no clinical features, or a patient has no clinical features, we would no longer expect to find the antigen because the antibodies cleared it. But what the immune system does is it thinks, well, once bitten, twice shy. So it keeps a copy of the antibody. And it keeps cells that make the antibody. The cells that can make the antibody quickly again, called lymphocytes. In fact, it's a specialised type of lymphocyte called a memory lymphocyte that remembers. And if the immune system is once again exposed to the antigen, then the lymphocytes thinks, oh, I've come across you before, I know how to deal with you, quickly makes up these antibodies, these immunoglobulins, which should then attack the antigen and kill it. Get rid of it before someone becomes sick. That's what we believe is going to happen. Now, we are still looking at secondary infection, but this is what happens in most infections. And there is evidence that this is happening in COVID-19 infection. Now, what this means is, if I want to... I was ill myself a few weeks ago after a flight. So what was it Did I have the virus? Probably not, but it's not impossible. But I've no way to tell. The only way you can tell is by looking for the antibody, the evidence that the body has fought off that infection. So we want an antibody test so we can see if someone has had the infection in the past. As of now, we don't have one. As of now, we only have the antigen test, which is very frustrating, very limiting. Now, something else I want to tell you, that we can stop this. This can be stopped because this virus will only reproduce in human cells. Now, it originally came from animals. It's originally zoonotic. It jumps species from an animal into a human being. But now, this virus, now we've cut off the animal source because the wet food markets in China have been closed down. Thank goodness. Now it's only coming from your cells to someone else's cells. And so we have these cells that line the airways, and we have these cells that line the airways. These respiratory epithelial cells. And they're quite famous cells, these, in biology, because they have these cilia, these little hair-like structures wafting from the top of them. So they have these cilia wafting from the top of them, like that. And the cilia is good because there's also cells here that produce mucus. Every so often there's a cell that produces mucus. That's called a goblet cell because it looks like an old-fashioned upside-down drinking goblet. And that produces mucus that goes onto the surface. And then the viruses and bacteria stick to the mucus and we cough it out. So what happens is in the infection, the virus, this tiny virus, is breathed in or gets into your respiratory system through your dirty hands or contaminating, or it can get in through the eyes as well, because remember there's tubes that connect the eyes to the nose. So the tears actually drain into the nose. That's why you get a runny nose if you're crying. So it's all connected up inside there. That's why it's so important not to contaminate the eyes. So the virus gets into the cells. And what this virus does, it takes over the genetic material of the cell. And it says, right, cell, stop making your own proteins and start making mine. And the cell's hijacked. So all you need is a few viral particles to get into the cell. Then this cell will be hijacked and start making thousands of the viruses, which will then shed from the surface of the cell. So only a few viruses come in, and untold billions and trillions of viruses go into the sputum of the infected, who is now the infected person. That's why they can cough it up in their sputum. And it will go onto surfaces and infect people by droplet infection, and to some degree by airborne infection. So the thing about these viruses is they're primitive things in one way, and they're absolutely brilliant and cunning scallywags. But the primitive things in they cannot reproduce on their own. They can only reproduce inside cells. And this virus now, the COVID-19 virus, is specific to human cells as far as we know. So it can only be propagated in human cells. That means if we can stop spread between humans, we'll stop this virus reproducing and it will simply go away. If we stop the virus spreading between humans, it'll run out of these cells to infect. It won't be able to infect them. The person's antibodies will make, the person's immune system will make antibodies to this virus. The person will clear that virus, kill all the virus in that person, or kill all the cells with the virus in that person. The immune system will eradicate the virus from that person. And if they haven't passed it on to someone else, the transmission will be stopped. We can stop this. It can be stopped. But that's going to require that we break the human-to-human transmission. This is what happens with SARS. We stopped it. It went away. SARS doesn't exist now in the world. SARS-1, the epidemic in 2002, 2003. And this one can be stopped, but we have to stop the human-to-human transmission. It's the only way through these respiratory epithelial cells. So this is a quite hopeful video, really. The virus will only reproduce in human cells. So if we can stop it going from human cell to human cell, we can stop it. The question is, of course, can we? Well, the answer to that is obviously we haven't. So let's look at some of my thinking on this. Now, Public Health England, some big boss have said that we might need to stop shaking hands. I think he just said this today or yesterday, although we're not there yet. Couldn't disagree more. Although I think we are there now. Unfortunately, we have to suspend a lot of social interactions, I think. Hugging, kissing, handshaking needs to stop for the time being. Once the virus is gone, we can start again. But I think it's time to have this social distancing now. Hundreds of thousands of people in South Korea are working from home. They are really practicing social distancing. Not possible for everyone I know. Now, Dr. Bruce Alwood, sorry if I pronounced your name wrong, Doctor. He was in charge of the team, or one of the team leads who went with the joint team with the World Health Organization to China. And someone put their hand out to shake his hands, which of course is nice. And what he did was he offered them his elbow. So it's like an old-fashioned thing in operating theatres. You can't shake hands, so sometimes people donk elbows instead. So don't care what you do this or donk elbows or nod, but we need to suspend these social niceties, I feel, for the time being. Now, the other thing I feel strongly about, where I'm really worried about threat, is isolating vulnerable people. And we're going to look later on at particularly, in fact, we might do that in a minute, who these people are, the vulnerable people. Institutional spread really concerns me. Hospitals, prisons, schools. Now, thankfully, children don't get severe forms of this illness, but they will take it home to their parents, we believe. They can be carriers. Some will get ill, of course, but hopefully most will not get a severe form, but they can be carriers. So all these institutions where people are close together. There's been prison spread in Iran and China. So we really need to protect these institutions. And for now, we need to avoid crowds. Now, I know it's difficult if you've got to commute in the underground or something. It's very difficult. But just think about how you can minimise it. And of course, once you've been in a situation like that, wash your hands afterwards, please. Enough said. I'll probably be showing you that again. Okay. Now, I think we'll do the news on a separate video today, I think, because I've gone on a bit about this. Now, vulnerable people. What good is it having a civilization if we can't protect those that are vulnerable in that civilization? This is the whole point of civilization. We protect the weak, or those that are temporarily weak. We look after the young, we look after the elderly, we look after the sick. This is what we do. So we need to think about who's going to be vulnerable. Well, anyone with immunocompromise is going to be vulnerable. Anyone with compromised immunity. Anyone with comorbidities is going to be more vulnerable. Hypertension, high blood pressure. Congestive heart failure. Chronic obstructive pulmonary disease. These long-term diseases. Poorly managed diabetes mellitus. Now, I'm fairly happy that, not happy, but I can think theoretically that if someone's diabetes is well controlled, that their sugar levels are low, that they are not hyperglycemic, that they should have reasonably good immune function. But the immune function will go down if the blood sugars are high. So if someone's blood sugars are high because their diabetes is poorly controlled, their immune function will go down. So it's the degree of control. Now, people keep asking me, my blood pressure is well controlled. Does that mean I'm more at risk? All I know is from the Chinese data, people with hypertension were more at risk. I'm sorry, I don't have data to answer that question just now. I simply don't know. I don't think anyone in the world knows the answer to that question. But I've been spending many, many years teaching student nurses to train people to make sure their blood pressure is well controlled and that hypertension is not allowed to persist. But that specific question, I don't know the answer to it. But just going back to the vulnerable groups. Now, this is, I've put that in small print, you probably can't read it. The epidemiological characteristics of an outbreak of 2019. This was a huge mega study carried out in China, published on the 17th of February. Data went up to the 11th of February. This was based on about 70,000 positive cases. Now, these were the figures. They found 0 to 9-year-olds, they found 416 people infected. And this is CFR, case fatality rate. This is the death rate. And thankfully, no children. 10 to 19-year-olds, the case fatality rate was 0.2%. And I think we should say that these case fatality rates are probably overestimates because of the large numbers of asymptomatic people or people with very mild illness that were not tested. So these are the largest numbers that we could expect. And I would actually expect the case fatality rate in 10 to 19-year-olds to be lower than that, especially with good healthcare. So I think if we take these as a maximum figure because of the undiagnosed cases in China, that wouldn't be a bad way to think. 20 to 29-year-olds, that was the number of patients they tested. That was the fatality. 30 to 39, that was the number they tested. That was the fatality. Well, tested, diagnosed with testing. 40 to 49, they tested that many, 0.4%. And again, remember, these we believe are upper estimates because of the undiagnosed cases. 50 to 59, it went up. 60 to 69, it went up. 70 to 79, it went up. And over 80, it went up quite dramatically. Now, these older age groups, of course, that have the higher case fatality rates, where more people died per documented case of infection, also have more comorbidities. So these are the people that tend to have type 2 diabetes. These are the people that tend to have chronic obstructive pulmonary disease. These are the people that tend to have congestive cardiac failure. These are the people that tend to have poorly managed or been diagnosed with high blood pressure, the hypertension. So whether it's the age per se or whether it's the presence of comorbidities hasn't really been dissected apart. I think it's probably going to turn out to be both. It's probably going to turn out to be both. So it's partly because these people are older, the immune systems are perhaps not as good as they once were, but also because these people have got more comorbidities. So that gives us a reminder of the vulnerable people that we need to be looking after more. Another example of institutions there with older people, and of course, are care homes. I mean, these are going to be, care homes to me are going to be very much at risk because they're institutions. We have groups of people living together, and a lot of people are going to have comorbidities and be in the older age group. So an outbreak in a care facility, a nursing home or assisted living facility, for example, we could expect a high mortality. So these are what we really need to think about. These are people we need to think about protecting now. And everyone should be avoiding crowds. And I'm going to do the news on the next video, but for now, don't forget, when you've been out, when you come in, when you could be contaminated, don't touch your face. There you go.